So this gentleman is in his 70s, and this, he presented to our GI group just with generalized abdominal pain. And we're gonna pass the little bit of free air that we see. So I'm not sure if I should just describe findings and have you guys, kind of give me some, tell me what you think, or I can just scroll and kind of show, take a look at the spleen or the multiple spleens here, the midline-ish liver with the pre-duodenal portal vein and a left IVC. Here we have the right IVC coming down and ending in the renal vein, and the left IVC coming around here and into the pelvis. Further, we have absence of the pancreatic tail and malrotation. What is this?
Some kind of, I know it's like that sequence of like polysplenia, truncated pancreas, left-sided IVC, but I don't know the name of it.
Yeah, so it's left isomerism or a heterotaxy syndrome. So we've got two like left sides, like we've got multiple spleen and a left IVC. Really cool case. I wish I had chest imaging so that I could show you the fissures, the lobes, because you should have no minor fissure. You should have two left lungs, essentially. So really cool and kind of rare. This one is not as serious as the asplenia, bilateral right-sidedness. People with asplenia often have a really severe cardiac abnormalities as well, and they present a lot sooner because of the cardiac abnormalities. But I don't have cardiac imaging and I don't have the lungs, to see what's going on above, but we have all the abdominal findings, which is really cool.
Tell them what we thought about the free air and the findings associated with that.
Absolutely.
Within the context of kind of a failure to thrive history.
Yeah, so we have a mobile cecum. We found our cecum up here in the right upper quadrant, and then we saw some bubbly lucencies in the wall, kind of in the wall of the right colon.
Window.
Say that again.
Show the lung window.
And some free air. And here, no, I like to do this. I like to do, I know it's really bright, you guys, I'm sorry. I love to do this, to look for air. Invert it. So there's a little bit of free air and some bubbly lucencies in the wall of the bowel, we think, and also some air in the vasculature. It's really kind of subtle. So we ended up calling this a benign pneumatosis case, just because we don't have any wall thickening really of the bowel wall. In the patient's exam, if the physical exam was very normal and no lactate elevation. And so we ended up saying this was a benign pneumatosis.
That's very cool. And I like your inversion trick. I've never done that, but I felt like I could see the pneumatosis well there. So that was really cool.
Sweet. So that's my case. It's been all the excitement so far this week.
As it was, yeah.
Cool. Roopa, you want to go next?
Yeah, sure. So I have two cases, kind of related, but let's start with this one. Can you see my screen okay?
Yes.
Okay. So 30-year-old patient came in with this finding. So I have sagittal T2s, axial T2s.
I think Gitanjali did show this, and I have some theories, but I'm curious what people think or if they want to.
Yeah, I have a companion one to show to this. So,
Like some sort of hernia,
okay.
but not just. Trying to figure out what's going down the inguinal canal here.
Yeah, it's like an enhancing mass. It was pretty T2 bright.
Right. So it was going down like where
It's a myxoid sarcoma.
good thought, myxoid, because it's bright on T2.
Right, yeah, and it's
Look at the morphology of it on the sagittals. Like, is there anything else you would describe on the T2s that's inside it other than areas of bright T2 signal? Like, what are these? What would we have called these?
like vessels, no?
Loboids.
Loboid.
Loboids, right? And then would we describe this as lamellated or laminated on T2? They kind of look like nicely, regularly arranged band-like areas. And the trick is to look at this in the correct axis. That's only when you will see the lamellation or the lamination they talk about. So multi-compartmental, like Steve said, it looks like where like a hernia of a hydrocele of canal of nuke would go into that labial region.
So I think last time we brought up an aggressive angiomyxoma because it can have that lamellated appearance, but this is an unusual location.
That's a good thought also. Those are again fleshy looking multi-compartmental tumors which can have this lamellated appearance. So pathology wise, they actually called this one a solitary fibrous tumor versus an angiofibroma. So it's one of those things where we tend to see some low T2 signal areas, but when we think of SFTs, we're not that used to thinking of lesions with flow voids like this. But turns out that these SFTs in the pelvis can actually have low T2 signal either from collagen, fibrous tissue, or flow voids, which are actual vessels. So that's why they can hyper enhance, look fleshy. Angiomyxoma is another good thought. Angiosarcoma is another thought. And all these tumors happen kind of in and around the pelvic diaphragm, either on the bottom side or on the top side. So when you see these large vulvovaginal or perineal masses with so much heterogeneity, flow voids, two big things to think about are SFTs and these aggressive angiomyxomas and angiofibromas. They're kind of along a similar spectrum. Let me show this next case.
Wait, Roopa, one thing. You had just said something about T2 hypointense, but you mean hyperintense, right?
Hyperintense, yes.
Yeah, okay. Because that's to me been a surprising finding, like, oh, you think fibrous, it's going to be hard.
It's not as hypo as you expect it to be, right?
Yeah.
It's more myxoid looking than true. Oops, we don't look at knees in this conference, sorry. Let me show you this one. So this one came in as an incidental finding. She was actually being imaged for some sort of a pelvic floor problem. She had had a vaginal sling placed, and then we found this mass. So this one's a little more hypointense on T2, like we like our imagination of fibrous tumors to be. This one intensely restricts. Didn't know a whole lot of history because she had had some sling placement and all that. We've seen a few things like foreign body granulomas to sling material or some post-surgical changes in these locations. It's kind of very retropubic. Didn't have any good history of endometriosis or anything, not that this looked typical in signal for that. No fibroids in the uterus for some weird leiomyoma type, low signal intensity, soft tissue. So this one also at pathology ended up being a solitary fibrous tumor. I think this is much more a common version of what we see with SFTs. So Aarti, can you see my screen still?
Yes.
Yes.
Okay, perfect. So just a few interesting things. In the more recent years, they've actually discovered more extrapleural SFTs than the classic pleural-based ones. And the pleural-based ones we know produce insulin-like growth factor, which is why patients can have hypoglycemia. And histologically, they call this a patternless pattern. And like our second case, when these are smaller, they can look more homogeneous. And when they are larger, they can look much more heterogeneous. And what I learned was that they can have a lot of hypervascularity and dominant low T2 signal from different reasons. So differentials we kind of spoke about. And then age more than 50, more than 10 mitoses per high power field, and size more than 5 centimeters are all higher predictors of malignancy in solitary fibrous tumors. Up to 20% of them can have a risk apparently. And because they are hypervascular, they can actually embolize these preoperatively. And if you get negative margins, the survival is great. So this was a nice paper which reviewed some other extrapleural SFTs. This one was a skull-based one, more homogeneous, low T2, intensely enhancing. This one was an extremity one, and the angio sequence shows these nice flow voids and kind of very heterogeneous enhancement. They can have some cystic areas interspersed. This one is in the bladder wall. So these are all unusual appearances of SFT. And the aggressive angiomyxoma, like Steve said, they look like tumors which cross multiple compartments. So they look like they're constantly trying to herniate. Like this one's going into the pudendal canal. This one has a neck here going into the ischioanal fossa. This one has large flow voids. So anytime we see these big pelvic masses centered around the vulva, vagina, perineum, we do need to think about angiomyxomas, SFTs, something in that spectrum. So these were two back-to-back cases I just pulled up. So
Very nice. I love SFTs.
I know they're so weird.
And in my sarcoma talk, I learned that they're the third most common retroperitoneal tumor after liposarcoma, leiomyosarcoma, and then solitary fibrous tumor. So I feel like they're not as rare as, I don't know, I thought in residency.
Right.
I thought they were just from the pleura.
I think in residency, they teach us too much about the pleura one, which is homogeneous, always enhances intensely. And I think our opinion of them is a little clouded. So that's why this conference is awesome, to learn about all these variants.
I see a radiographics article in somebody's future.
Sure.
Cookie's not here, so the pressure's off.
Yes.
Okay, can you guys see my screen?
Yeah.
Okay.
Sure.
So this is my first case, and it you can see the finding pretty easily here. We see this hypoenhancement of the kidney, a little bit of a rim sign, so like a little bit of preserved enhancement of the rim. And so we called this a renal infarct. The patient didn't seem to have any vascular disease. Their renal arteries looked open. I could trace them even though this wasn't a CTA. And the other interesting finding is up here. So they've got some, consolidation at the atelectasis of their lungs. But they've also got sorry, what?
Was this COVID?
Yes. So
COVID.
lung, and then also renal infarct from COVID.
Yeah.
So, and then I have one more companion COVID case, and then I'm going to show you a couple of slides about COVID in the abdomen. So this was a patient also who had COVID. You can see at their lung bases, they've got not as severe findings, but they do have, again, bilateral ground glass at their lungs. And then this patient had abdominal pain. They were an outpatient and everything was looking okay, but we can see this subtle finding here, more easily seen on the lung windows, where we have pneumatosis of the cecum. And patient wasn't very sick. And so, this is another kind of, benign pneumatosis, but we think this was like also related to COVID. So I'm just going to show you some.
Aarti, is it more ischemia?
What'd you say?
Is it more ischemia, like vasculitis type from the COVID?
Yeah, exactly. So I just read a couple of papers about COVID. So COVID can, instigate this diffuse inflammatory process, but it can also have direct toxicity on cells. It enters the cells via this ACE2 receptor. And there's higher numbers of these in the lungs. So that's why it often affects the lungs, the bowel, and the vessels. There was a paper from MGH in May where they looked at 400 patients. It was like preliminary findings. And there were, out of the 400 patients, of their ICU patients, which I think was about 20, 30% of them had bowel wall thickening. They also had pneumatosis. And the other major finding that they found on these patients on CT scans was gallbladder sludge, also on ultrasound, from biliary stasis. And then in abdominal imaging, in September, there was a review that, there was a paper that reviewed 36 papers about COVID in the abdomen. And one of their findings was that 16% of patients with COVID may only have GI symptoms. So even if they have no other symptoms, if we see bowel wall thickening, that is something we might want to raise. And then they also found all these other findings related to sort of the bowel, like fluid-filled bowel, perforation, intussusception, and ascites. And then for the renal findings, this has been reported. I only found like 3 case reports, but one of them had 2 patients. But one of them said that these may be, there may be more renal infarcts happening, but they may be underreported because these patients generally have an elevated creatinine because COVID has direct nephrotoxicity. That's why we're seeing so many renal ultrasounds being done on them, but they're not necessarily getting contrast enhanced CT because they're trying to not, give their kidneys another hit. So there may be more renal infarcts than we realize. And the consequence of this is that it affects their anticoagulation. So every inpatient will be getting prophylactic doses of Lovenox. If they have a high risk for a clot, they will double the prophylactic dose. And then if they end up with thrombi, such as like COVID-TOE or like a stroke or even a renal infarct, they might even start therapeutic dose Lovenox. Any questions?
Very cool, Aarti. It's a big infarct for.
Yeah. And they said they were gonna, that was gonna change their anticoagulation. So it was interesting. Okay, this is my next case. Steve, you're a kidney specialist, right? I know you're prostate.
Sort of. I've lectured on renal disease and renal tumors for years.
Okay.
But if you're showing some sort of, unicorn, I might not get it.
No, well, we'll see. So anyway, these are, this was a patient, it was like a middle-aged female. She had this renal mass. You can see it's pretty large and it's involving the renal sinus. It's kind of T2 intermediate or hypointense compared to the parenchyma. And then this is the corticomedullary phase. We can see that there is fairly robust enhancement with like a central scar. And then when we go to the delayed phase, we can see that it basically kind of washes out, but the scar enhances. So does anyone know what that series of findings is called?
I should probably know.
I'm sure you'll know it once I say it, but it's so when you see that the, one part of it goes from hyper enhancing to like washing out, but then the central scar has delayed enhancement. That's called segmental enhancement inversion. I think it can be like areas where like half of the lesion does it, but it can also be where a central part does it. And that was thought to be a sign that is suggestive of an oncocytoma. But in the literature, basically it says like, now you really can't tell between that and an oncocytoma and a chromophobe RCC when you have segmental enhancement inversion. But it's more suggestive of those 2 entities than something like a clear cell renal cell carcinoma. So what do you guys think? Do you think this is an oncocytoma? Do you think this is a chromophobe RCC? Can't tell. Want to see any other imaging?
What about the non-contrasted series?
How's that going to help you?
Aren't the chromophobes sometimes T1 brightish?
Maybe. The series I wanted you to ask for is the diffusion, because, and I'll show you a chart in a second, but basically this lesion had very severe restricted diffusion. And when you're deciding between an oncocytoma and a chromophobe, if you have marked restricted diffusion, that would lean you towards a chromophobe. So this patient ended up getting a nephrectomy, and this was their path. It was a chromophobe RCC. Chromophobes are a better histology of RCC. They don't end up grading them, so there's no grade 1 through 4. But they can have sarcomatoid features. So in this case, it did not have sarcomatoid features. It did interestingly have heterotopic bone formation, but I had a CT and there was no calcification. So this was just kind of like at the pathologic level. So one thing I wanted to share with you guys, I think I talked about this before, but this is, so Ivan Pedrosa at UT Southwestern has come up with this thing called the clear cell likelihood score, or CCLS. Have you guys seen this?
Yeah.
Yeah, and it was cool because it worked in this case. And so basically, first of all, you want to take out the AMLs and you want to take out cystic masses. So this is just for solid masses that are indeterminate. Then you look at their signal intensity on T2 against the renal cortex. So ours was basically iso-intense to the renal cortex. Then you look at the enhancement on the corticomedullary phase, which ours was moderately enhancing on the corticomedullary phase. So basically we go down to this pathway, oncocytoma versus chromophobe, and he gives that a CCLS score of 2 to 3. And if it has segmental enhancement inversion, you would give it a 2. So what does that mean? Basically, this whole thing is trying to predict what renal mass is going to be a clear cell carcinoma, because those have a much worse prognosis than papillaries, chromophobes, and anything else benign. So when they look at their masses, everything that got a CCLS score of 1 to 2, none of these were clear cell renal cell carcinomas, and their recommendation is that these can undergo active surveillance. If it gets a CCLS score of 3, you may want to consider a biopsy, because some of these will be clear cell carcinomas. And 4 to 5, generally they would go to surgery. So going back to my case, it was probably in this oncocytoma chromophobe category. We gave it a CCLS score of 2, so we didn't think it was a clear cell. However, one thing that's not in this chart that Ivan told me is that he's going to add it to the chart, which is that if there's marked restricted diffusion, then you are going to lean towards a chromophobe. And in this case, because the patient was younger and the mass was 8 centimeters large, that was the reason to resect this mass. But in general, if you have like an older patient and you think it could be a chromophobe, you could do active surveillance.
How is he judging the enhancement? Just subjectively?
Do you see here? I don't know if it's legible, but it's corticomedullary phase. If it's greater than 75% than the renal cortex, 40 to 75 or 40%, less than 40%.
For the internal percentage controls.
Yeah.
I guess it helps triage stuff that you don't want to resect.
Yeah, the whole point, and actually he was saying, I'm going to show you one more renal case, and it was a very cool one, and I asked him about that one too. But the whole point of this algorithm is really to make you more specific for clear cells and make you feel more confident about doing, not necessarily doing surgery for these much more indolent and benign ones. So this is for solid masses. I am now going to show you a cystic mass. Okay, so this is my cystic mass. I'll make it bigger. Okay. Or cystic lesion. Here's the post-contrast.
Can you show it in coronal too?
Yes. One thing on the post-contrast you might notice, there's like some nodular septae.
Yeah.
And then I'll show you the coronal. Okay. To me, it almost looked like it was kind of herniating.
Yeah, like an MLCN, right?
Yeah. So what do you guys think? Do you think this is a multilocular cystic nephroma? Do you think it's a multilocular cystic RCC? Do you think it's something else?
I mean, the problem with the nephromas are you know, it's going to overlap some of the Bosniak 3s and 4s, and so you're a little stuck sometimes.
Yeah.
But too much nodular enhancement.
I don't like the nodules.
Yeah. So that's exactly, so we called this, we said, you know, it could be a multilocular cystic nephroma of a duplicated collecting system, because I think like we were seeing that part and then a separate kind of collecting system here.
Almost looks like a bifid sinus.
Yeah, but we said that there's too many enhancing, you know, nodular thickened enhancement. And actually down here, there's even like, you know, real nodules here.
Oh.
So they ended up getting a total nephrectomy. And this actually came back clear cell carcinoma with extensive cystic change and hemorrhage with papillary features grade 4.
Wow.
Wow, advanced. We're not surprised, though, honestly.
Yeah, so it was very interesting. And I showed it to Yvonne, and he said he's never seen one that was a grade 4 like this. But kind of getting back to your point about the multilocular cystic nephroma, so there's something called a multilocular cystic RCC. And it's actually now called this whole thing, multilocular cystic RCC of low malignant potential. That's when you have like a single layer of clear cells, but no nodules or solid growth. And in the literature, there's absolutely no cases of metastatic disease. But you also cannot distinguish these from multilocular cystic nephroma. So this is why, you know, these are going to end up being these like Bosniak 3 lesions. They're going to have multiple cysts, septations, but no thickened nodular components. And Yvonne was saying that actually now they're saying like, you know, both of these are very, very benign and indolent. They have no cases of metastatic disease. So you may even want to consider watching, even if you think it's, you know, you can't distinguish the nephroma from the RCC. On the other hand, my case, a clear cell RCC with cystic features, these are like the Bosniak 4 lesions. They have enhancing nodules, and these even rarely metastasize. So they do have a much better prognosis than other clear cells. That's why my case actually is quite rare, because it turned out to be a grade 4, which is very unusual. Usually they're very low grade and do really well.
And what you said kind of reminds me of the movement that I've seen over the last, I want to say 7 years or so, where it's almost getting to the point where we don't have a real Bosniak 3 category anymore. Everything in 3 is kind of like a 2F, what we used to call a 2F, meaning a potential to follow lesion. Instead of, you know, it's like you really have like simple cysts, minimally complex cysts that are benign, and then you have things that you want to follow, and then you have things that are, you know, potentially surgical BOS4s that you gotta go after.
Yeah. And that's what Yvonne was saying. Like that was the whole reason of doing the whole revision in 2019, was that we want to start lowering the diagnosis of these, because, you know, it's pretty severe to have a nephrectomy. You really want to do nephron sparing as much as possible. And a lot of these more cystic RCCs tend to be, even if they are an RCC, they're on the very indolent or benign end of things. So we want to kind of decrease our resection rates of these.
Right.
And then I have one more case. Oops. Okay. This one is courtesy of my fellow Jake. So,
Oof.
okay, so we have a renal transplant on the left, and we've got this process on the right.
Like a pancreas transplant?
Yeah, good. So this is a pancreas transplant, and then what else is going on with that?
There's peripancreatic heterogeneous fluid, so hematoma. I don't know if I saw some extravasation lower down.
Or is it pancreatitis in the
True.
Yeah, so that's like basically what this case is about. So this is the portal venous phase. You'll see the pancreas, and then you can see this is the mucosa of like the jejunal loop that's like wrapped around it. And this is even part of that jejunum fluid filled that's wrapping around it. And this is the wall that's actually really edematous. And I'll go to, they did like a later phase. This confused me at first, but I was like, why is that like all that fluid enhancing? Like, is it extravasating? But I think it's actually just the wall of that jejunal wall that's kind of got some delayed enhancement in it. So this was a case of pancreatitis in a pancreas transplant. And so you can see that this is the pancreas transplant, and then the severely edematous jejunal loop, and then I think fluid between like the pancreas and the jejunal loop as well, kind of all trapped in this like adhesive area probably. And then actually there's a really nice example of the vascular supply to a pancreas transplant. So here's your external, your common iliac artery. Let's see, common iliac artery. And then this is your Y graft that is going to be attached to a, both the SMA, which would be probably this one, I think, as well as the hepatic artery. Oh no, wait, sorry, the splenic artery. So this will be the splenic artery going along the pancreas, and then I think this is the SMA over here, or maybe the reverse. I have the have it.
And those vessels, the splenic artery and the SMA, are from the transplant piece, right?
From the patient, yeah. So they'll like resect the splenic artery will be going along. So actually this must be the splenic artery because it's going along the main part of the pancreas.
Right.
And then the SMA with like the branches feeding the head, the pancreatico-duodenal arcade. And then in order to connect those two, they take the the patient's iliac bifurcation and they make this Y graft. And then they'll hook it into the recipient's iliac artery.
Yeah, we don't see those very much. I've seen like one pancreas transplant here in years. It's just not really done very much in New Mexico, I guess.
Yeah, I think we do about 15 per year. But anyway, so this is the anatomy. So they harvest the entire donor pancreas with a piece of duodenum that they'll sew to the small intestine. The SMV and splenic vein, which naturally flow together to the portal vein. So you don't need to make any anastomosis there. You just anastomose it to the recipient. And then for the arteries, you take the SMA and the splenic artery, and then you attach them to this Y graft because they don't normally attach to each other. And so you only have one anastomosis to the common iliac artery over here. So, yep, this is just pancreatitis in a pancreas transplant.
And did they do okay? I mean,
I think it's still in progress because they actually ended up doing a pancreas biopsy, and they're still kind of have ongoing pancreatitis. So, but yeah, that's one of the problems with pancreas transplants. That's why they don't do a lot of these, is because if you have rejection or any kind of complication, you'll get pancreatitis, which is much worse than, for example, if you have like rejection of your kidney. It's pretty indolent, it's just sitting there.
So the pancreatitis can be incited by a rejection.
Mm-hmm. Yeah, it's non-specific. It can be from different things, but it can also be from rejection. Yeah. Yeah, and they basically only do it for brittle diabetics who are already going to be getting a renal transplant and are already going to be on immunosuppression. And if they have brittle diabetes and they have hypoglycemic unawareness, then that can be very dangerous, and therefore that's why they would transplant in the pancreas.
Aarti, this morning in my pancreaticobiliary triage conference or hepatobiliary triage conference, I brought up a concept that was kind of new to me. It was based on a paper I reviewed where hypertrigliceridemia was considered the principal etiologic factor behind pancreatitis in a lot of cases. The surgeons that were in the room were a little skeptical of that and said, well, you get hypertrigliceridemia in the setting of pancreatitis, and so is it chicken versus egg, blah, blah, blah. But the article I read did sort of make a case for it in terms of the metabolism and the science of the pancreatic parenchyma. I don't know if you've ever heard of that.
I have not heard of that, but that is very interesting. And I know that, gallstones and alcohol are the biggest, but after that, there's like a huge list. But yeah, maybe hypertriglyceride. I don't know.
It was a theory that was presented, like I said, in this review paper about how hypertriglyceridemia basically promotes and or leads to pancreatitis and is, according to these authors, a principal etiologic factor. But I don't think everybody has caught on to that yet. So I just wanted to know if you'd heard it yet.
I've just heard it now. Thank you.
It was kind of new to me. So look for that anyway. See if you are swayed by people's arguments for or versus against.
Yeah, I'll look for it. Awesome. Okay, anyone else have cases? Last call. Okay, I think we're gonna end.